Assalamu alaikum and good morning. Thank you for inviting me to this wonderful meeting. So I will be talking about T-cell lymphomas, and I want to apologize in the beginning that the data here is much less than what we've heard all this wonderful talks yesterday. But I'll try to do my best and try to show you some new things. So the first, I have two talks. The first one is sort of progress and future directions in management. So these are my disclosures. So I just wanted to sort of point out, how we've progressed in this field from recognition of T cells as separate entities from in the early 1960s to now the newest classification, 2022, that recognizes almost over 85 different subtypes of T cell lymphomas. So it's not one disease, it's multiple diseases. And then what I've pointed out, a lot of the progress has been in just trying to understand the different subtypes and how we differentiate between them. But there are some interesting therapeutic highlights as well. Pralatrexate and romidepsin were actually the first T-cell lymphoma specific drugs that were approved for the treatment of relapsed T-cell lymphoma. Before that, and even now, we usually just borrow treatments from B-cell lymphomas and try to treat these diseases as best as we can. But now we have some certain specific drugs that can actually treat these diseases that are not as effective in B-cell lymphomas, and I'll talk about those. There's also the HDAC inhibitors, belinostat, chidamide, and mogamulizumab. I'm sorry the slide is not coming out very well. They are pointed out in red over here. You have brentuximab vedotin that we heard this excellent Echelon 1 talk yesterday, but I'll talk about what brentuximab vedotin can do in T-cell lymphomas. And then we have, sort of more drugs that are coming through, and then we'll be going through that. However, when we look at sort of the clinical progress that we've made in treating these diseases in the clinic, that's actually not as impressive. So this is actually a slide from 2004. Dr. Armitage pointed out that T-cell lymphomas don't do as well as B-cell lymphomas, as you can see down here. And then Dr. Vos in 2008 looked retrospectively. This was the International T-cell Lymphoma Project. The first time we actually had some epidemiology collectively throughout the world to look at how these patients do. And as you can see, the yellow line is anaplastic large cell lymphoma, ALK positive, but everything else at 5 years, your survival is not that great for most subtypes of T-cell lymphoma. More recently, we've had some more data coming from prospective registries, which looks very similar to Dr. Vos's studies. Again, 5-year survival around 30 to 40% with current therapies, current standard therapies. So we have a lot of work to do, and to try to improve these outcomes for these patients. So just a few words about the updated 2022 classification for T-cell lymphomas. I can't go over the whole details, but I will focus mostly, and most of this talk is going to focus on nodal T-cell lymphomas that are the more common subtypes, nodal peripheral T-cell lymphomas. And again, as we are getting better understanding of these diseases, we are starting to learn that, we have, particularly with the gene expression profiling and NGS sequencing, we're trying to figure out, even it's not just histologic subtypes, but also molecular markers that can help us in diagnosing, as well as prognostication and treatment of these patients. For example, peripheral T-cell lymphoma not otherwise specified. We now have two sort of major subtypes, the GATA3 and the TBX21. Subtype with different prognoses and maybe even different therapeutic approaches that should be used to treat these diseases. So PTCL-NOS is one big one. And then the nodal T cell lymphomas with T follicular helper cell origin. This is sort of like a new category where you have the angioimmunoblastic T cell lymphoma. We also have nodal T follicular helper cell and nodal T follicular helper cell NOS subtypes. All of them actually express these markers that have been pointed out here. And they have a similar gene expression profile. And they're actually, if you look at the genetic profile, it's a little bit different than the other subtypes, and which has some therapeutic implications. And the third large big category is anaplastic large cell lymphomas, which we all know the ALK positives, with the immunohistochemical staining. If they're ALK positive, the patients have a good prognosis. But even within the ALK negative ALCL, you actually have some genetic markers like DUSP22 rearrangement. You can pick that up by FISH. Actually has a better prognosis as compared to the DUSP22 negative. So there are, now we have tools to make these distinctions and possibly treat these patients differently. Moving on. So the main questions in treating T-cell lymphomas, what is the best regimen? I mean, we've always used CHOP-based regimens, but that debate continues in all the T-cell forums. And so I'll show you some data about how to pick the best regimen, or at least how I try to pick the best regimen for my patients. Stem cell transplant in first remission. That's considered, at least in the U.S. and where I practice, it's almost standard for nodal diseases if patients go into remission, but the data is not exactly very clear, and there are some centers that don't always offer that, and so we'll address that a little bit. Then you have relapse disease. What do we do when patients relapse? And a lot of our patients actually in the clinics are relapse patients because upfront therapies are just not that effective. Role of allogeneic stem cell transplant is still considered the only curative therapy for T-cell lymphomas. And then, of course, there are patients, special populations, elderly, frail patients, because again, the most common age of presentation is 60 and above. So there are comorbidities to deal with in these patients. Okay, so, and then there's some rare subtypes which I will not be able to address. So if you look at the NCCN guidelines in 2023, this is sort of what it looks like. They don't really give you any specific recommendations other than for anaplastic large cell lymphoma or CD30 expressing T-cell lymphomas, other histologies, to use a brentuximab vedotin or CD30 directed therapy in combination with chemotherapy. Everything else is sort of alphabetically listed, so you can pick and choose whichever one you want. Mostly they're CHOP-based or CHOEP-based therapies. And again, at the bottom, you can see that at least in the NCCN guidelines, it is recommended that you offer autologous stem cell transplant if the patient achieves a complete remission. Okay, so let's look at some of the data. So the first thing, sort of major breakthrough, in my opinion, that came in the treatment of T-cell lymphomas is the use of brentuximab vedotin in combination with chemotherapy for upfront treatment of T-cell lymphomas if they express CD30. And this is the famous ECHELON study. It is also the first randomized study in treating T-cell lymphomas, and it was a large multi-center study with over 400 patients that were randomized either to A plus CHP, A standing for Adcedris or brentuximab vedotin's commercial name, plus CHP is the CHOP without the vincristine, versus CHOP alone. And patients were randomized. This was a double-blinded study. The 2/3 of the patients on this trial were anaplastic large cell lymphoma. It's important to keep that in mind because that, in my mind, tends to skew the data a little bit because anaplastic large cells always they do better. However, the results were actually quite impressive, and this is the 5-year update, which was presented. This was originally presented in 2019, and there is a 5-year update recently presented at ASH. What you see is actually that the progression-free survival, which was the primary endpoint of the study, was doubled, almost doubled, 48.2 months in the A plus CHP arm versus the CHOP arm, with a 29% reduction in their progression, in the risk of progression. And there was a 34% reduction in the risk of death with the A plus CHP arm. So overall survival was also improved. They did not look at the question of transplant in this study. It was left up to the physician's discretion if they wanted to offer transplant or not. But it clearly showed that, looking at this data, that if you have CD30 positive T-cell lymphomas, that you should offer them brentuximab vedotin-based treatment in the upfront setting. However, there is a sub-analysis that came out because, again, 2/3 of the patients were anaplastic large cell lymphoma. And clearly, if you look at the middle part of this slide, the outcomes are much better, or the results are much better in anaplastic large cell lymphoma. But if you look at angioimmunoblastic T-cell lymphoma, for example, or PTCL particularly, actually CHOP seems to be doing better for angioimmunoblastic T-cell lymphoma and progression-free survival. And so, again, the numbers were small, and we never really make recommendations based on sub-analyses, but this is food for thought. So, at least in this study, when we've looked at this over and over again, for non-ALCL histologies, the data is not as clear, and we need to do some work. So here's another study. This was our City of Hope study where we basically took the same approach. This was not a randomized study. but it is CHEP because we use CHOEP as upfront therapy. And so remember in Echelon 2, they had used CHOP as the comparator arm. In this case, it's CHEP plus BV. And what I'm showing here is data that is not ALCL as much. So you can see that even in non-ALCL subtypes, and even with decreased less than 10% or more than 10% expression of CD30, I'm sorry, I think I went back. The outcomes are pretty good. Response rates are pretty good. They're almost 90%, 80 to 90% overall response rate with good CR rates. So this is our study, and we're actually going to expand it, but it's going to be non-ALCL histologic subtypes to sort of see if this, the use of BV actually holds up in this group of patients. Romidepsin plus CHOP. So this was the other randomized study that was being carried out because romidepsin, as you know, is approved for the treatment of relapsed PTCL. But what about if you combine it with CHOP? And the initial phase 1 studies were promising. The response rates were almost 78%. So again, this was randomized to CHOP again. But in this case, it did not meet the progression-free survival as an endpoint. So this really didn't make it to the NCCN guidelines. In fact, this actually led to the withdrawal of romidepsin from the indication to treat T-cell lymphomas. It's still available, but it's sort of. But if you look at the subgroup analysis, in this case, if you look at T follicular helper subtype group, there you do see that there is actually some, the line is to the left, and there's actually a benefit to using romidepsin in the upfront setting. So perhaps if they had done we had thought this through a little bit better and maybe focused on this particular subgroup, this could have been a positive study. The interesting thing was that the duration of response was longer in patients who got the Ro-CHOP versus the CHOP alone. So this was a negative, it was reported as a negative study. But again, there are things you can learn from it. Another interesting upfront study is the use of azacitidine. And again, epigenetic agents are effective in T-cell lymphoma. So we had, for the longest time, focused on HDAC inhibitors, but certainly hypomethylating agents are now becoming more prominent in this field. And this is a study of oral azacitidine plus CHOP, came out of Cornell, and they actually looked at, also did some biomarker analysis to see if they could figure out which patients did better. They focused on the fact that, or the study was designed that because the PTCLs arising from T follicular helper cells have mutations in the epigenetic pathways, TET2, ROA, DNMT3, and IDH2. And so it made sense to use something that could sort of modify that pathway. So they designed this study of giving a loading dose of oral 5-azacitidine before each cycle of CHOP. Patients got 6 cycles of this combination, and then they, then they were followed, and so they also could get a stem cell transplant at the end of this. And what they found was that the outcomes were actually pretty impressive. The response rates were pretty good. A lot of patients achieved CR, and when they looked at the sort of mutational analysis, they found that patients who had a TET2 mutation had a favorable progression-free survival, as you can see down here. If you have a DNMT3A mutation, however, that was correlated with a worse outcome. So this regimen is now being evaluated in a larger alliance trial. So they're looking at 3 possible regimens. It's CHOP or CHOEP versus CHOP or CHOEP plus duvelisib, or CHOP and CHOEP versus 5-azacitidine. Plus 5-azacitidine. So we'll see which one comes out as a winner and which subtype. All right. What about chemo-free combinations? So I talked about frail patients, and we can't always give CHOP chemotherapy or even or mini CHOP sometimes to patients with, who present with these diseases. So we actually did this study with Northwestern and Cornell using a combination of romidepsin and Revlimid in elderly patients or patients who we thought were not eligible for chemotherapy. So it was a small study. There were not a lot of patients, only about, I think it's 23 patients who were enrolled and 20 were evaluated. There was, patients were able to tolerate the treatment. We had to lower the dose of romidepsin quite a bit to like mostly 10 or 12 milligrams instead of the 14 milligrams. Safety profile was pretty good, and we saw some efficacy in patients with T follicular helper subtype, as you can see that in the curves over here on the right side. So patients tolerated it well, but again, it was a small study, and so we were not able to, we can't recommend that to all patients, but certainly an option for studying further. So what do we know about upfront therapies so far? For nodal subtypes, this is how I look at it. There's a lot of data. There's a lot of combination studies that have been done. You have brentuximab vedotin, which, as I've shown you, is a randomized study, a randomized trial. But we've studied CHOP with pralatrexate, for example. Again, these are phase 2 studies. CHOP with belinostat has been studied. They're now trying to evaluate that in a more randomized fashion. There's a study ongoing with CHOP plus pralatrexate, CHOP, belinostat versus CHOP. CHOEP plus Revlimid was looked at. The hematologic toxicity was pretty high in that study. 5-azacitidine and CHOP I just showed you. And then there's combinations of other HDAC inhibitors. So the first recommendation is always look for a clinical trial if you can. But if not, then this is my treating diagram. If it's a nodal subtype, and they're anaplastic large cell lymphomas, I think we have pretty clear data that it should be a BV-based regimen. So I use either BV-CHEP or BV-CHIP for upfront therapy. For elderly frail patients, I've used brentuximab alone and actually been able to get them into remission. If it's CD30, if it's a non-ALCL subtype and you have CD30 positivity in the tumor, the question is how much CD30 positivity do we need, and I'll discuss that in a minute. You can still use BV-based regimens. I tend to do that. If they're CD30 negative, then it's, there's no point in adding brentuximab, so we do CHOP, CHOEP, or mini-CHOP in older patients. Okay, so just a brief talk about etoposide and stem cell transplant. This was actually a very interesting study in Blood last year that came out of the Nordic group that actually looked at the impact of etoposide and stem cell transplant on the outcomes of patients with T-cell lymphomas. And they actually also looked at time, the period during which the patients were treated. So from 1989 to 2008, at the bottom left here, the outcomes were worse than if the patient got treated between 2009 and 2018. And it looks like if you added etoposide, especially in ALCL patients, the outcomes were better. And certainly stem cell transplants seem to make a difference in their outcomes. Now remember, this comes out of the Nordic lymphoma group where they used CHOEP followed by a stem cell transplant. So it was patients were uniformly treated. But it's pretty good data that shows that you actually can improve the outcomes of at least younger patients if you can give them intensive therapy. Okay, I just sort of put that in to break the slides a little bit. Let's talk a little bit about relapse disease. So in relapse disease, the goal is to try to get into remission. In my mind, the goal really should be to get them to an allogeneic stem cell transplant if possible, because at the moment we know that that's the only positive curative therapy. So the goal of any salvage regimen is to get them into that state where you can take them to an allo transplant if they're young, without comorbidities, et cetera. But the problem is these are rare diseases. They're heterogeneous, as you already all know, and we've been emphasizing. And it's kind of, what I always find is that there's limited interest from the pharmaceutical industries in trying to treat T-cell lymphomas. B-cell lymphomas are a much bigger market. So we're kind of left with all the crumbs that come through. So here's the NCCN guidelines for relapse disease. Again, clinical trial is preferred. It's at the top. And everything else is listed in an alphabetical order, which to me tells me that we can't really say which one's better than the other. So you have a whole list of things that you can use to treat T-cell lymphomas in the relapse setting. Some of them are specific to T-cell lymphomas, and some of them are just general lymphoma treatments like GEMOX and ICE and ESHAP, et cetera. You just have to pick the right, try to look at your patient and see what you can offer them to get them into a remission state. So let's talk a little bit about some of the different subtypes. For relapse PTCL NOS, there is now gene expression profiling data to indicate that there are two major genetic subtypes. There's the GATA3 and subtype, and there's the TBX21 subtype. They have different gene expression profiles, as you can see right here. So you can certainly look at these by GEP expression, but that's not always possible in the clinic. But there is also an IHC algorithm that you can use to differentiate between these two subtypes. Again, this is mostly research at the moment, but the outcomes of these two subtypes are different with current standard therapies. So if you have a GATA3 subtype, it has a worse prognosis than TBX21. So down the line, I think we can use that data to try to figure out which treatments should be offered to maybe somebody with a GATA3 subtype should get an allo transplant in the first remission instead of an auto. But if you look at the known treatments, so again, the NCCN guideline lists all these things, but the response rates may be different in different subtypes. So for pralatrexate, the response rate is about 29 to 30%. It's mostly across all subtypes. So it's a useful drug for these patients. You don't have to admit them to the hospital for ICE or DHAP, et cetera. Romidepsin, again, 29 to 30%. Duration of response is 18 months. Belinostat is another HDAC inhibitor. Response rates are a little bit slower. But again, if patients respond, they can carry on for a while. Brentuximab vedotin, if you have CD30 expression in PTCL-NOS, you can certainly use it. The response rates are not as high as in the ALCL in the relapse setting, which is about 86%. So the newer agents, duvelisib, which is a PI3 kinase inhibitor, and I'll show you data on that in my next talk, has a pretty high response rate, about 48%, and it's holding. We have more mature data. It hasn't been approved yet by the FDA, but certainly I've used it in a lot of patients. And I know it's becoming less popular in follicular lymphoma, and actually the indications have been taken away. But in T-cell lymphoma, we've been fighting for it. We don't want the FDA to actually take away duvelisib. So hopefully we'll get approval for that. Ruxolitinib, a JAK-STAT inhibitor, an 18% response rate. So another possibly promising agent. And then another agent, valemetostat, which is an oral EZH2 inhibitor, is actually quite promising. So that data is also maturing, and we may be hearing some information on that at ASH. Response rates of 55%, and much less toxicity than duvelisib. So I think we have some newer targeted agents that are very promising. If you look at T-cell lymphomas with the T follicular helper subtype, where the epigenetic mutation frequency is actually quite high, it makes sense that epigenetic agents will work better in these subtypes. And indeed, if you have, look at pralatrexate, 8% response rate. So not very effective, though it's a questionable data. There are some studies that have shown that response rates are as high as 52%, but those are post-marketing studies. But belinostat has a response rate of 46%. And so that's pretty high. Brentuximab, about 54 to 38%. Duvelisib and valemetostat also higher than PTCL-NOS, 67%, 57%. Hypomethylating agents work. We looked at, there's some interesting combinations. 5-azacitidine romidepsin was studied at Columbia and Cornell with an 80% response rate and 60% CR rate. So it was a small study, but certainly it indicates that maybe combinations are the way to go. Romidepsin plus Revlimid is my favorite combination. It has a very high response rate, particularly very effective in transformed mycosis fungoides, which we're not talking about today, and then a JAK-STAT inhibitor. So targeted agents may be the future for T-cell lymphomas. ALCL, anaplastic large cell lymphoma. Yeah, I'm getting to the end. ALK positivity always improves outcomes. If you have ALK positive patients with a low IPI, the response rates are very good. Also DUSP22 rearrangements and improve outcomes, but P53 mutations actually worsen outcomes. So you can, and this can be actually, this is now up in the clinics, and we can use that information to talk to the patients about prognosis, and especially the question of transplant. In terms of treatment, if you have ALK positive, certainly ALK inhibitors are very effective in the relapse setting. Pralatrexate, romidepsin are effective, but what I wanted to show here is that duvelisib, actually in the PRIMO study, the response rates were not as high in ALCL. So maybe this is not the subtype where you would want to use a PI3 kinase inhibitor. There are some alternative approaches to treat these patients, like you do any aggressive lymphoma like ICE or ESHAP to get them to transplant. Gemcitabine certainly is a great drug for relapsed PTCL in combination. CD30 expression is variable. I just wanted to talk for 2 seconds about CD30 expression in response to BV. The responses are highest in ALCL, there's no question. But the expression of CD30 is variable in different subtypes of T-cell lymphomas. But interestingly, when you look at response rates in the different trials that have been done with brentuximab vedotin in both PTCL and CTCL, responses were seen even when CD30 expression was zero. So it makes you think that maybe our ways of detecting CD30 may not be ideal. And so this question certainly needs to be studied more. Finally, 2 more things. P53 mutations and CDKN2A mutations indicate poor prognosis. That's not a big surprise. So if the patients have that mutation, you maybe start thinking of finallo-transplant early. Allogeneic stem cell transplants have shown to be, effective in relapse disease. We certainly offer them in patients even with either poor prognosis, patients who don't get into remission with upfront therapies, or certain histologies like hepatosplenic T-cell lymphomas and gamma deltas. And this is just my little diagram of how to make sense of all of this. I've already discussed most of it. And finally, the conclusions, these are rare diseases, heterogeneous. We need collaborations to really study these better. And again, allogeneic stem cell transplant is still the most important treatment modality for these patients. And this is our City of Hope campus.
Thank you very much, Dr.